I am Mohammad Faisal Khalid. I'm one of the interventional cardiologists here at Trinity Health System. I do take care of patients with different heart disease and practice general cardiology and interventional cardiology. I like cardiology because of a lot of reasons. My interest in cardiology develops first time when I did my rotation during my med school, and this interest in cardiology has grown since then. There are a lot of reasons for that, starting from personal being taking care of a lot of patients in my family because heart disease runs in my family. And that is one of the most common cause for heart attack, heart disease, and mortality in the US and all over the world. And also this is one of the specialty in medicine where you can take care of the patients with a wide range or spectrum, starting from treating their overall medical risk factors for heart disease like high blood pressure, diabetes, cholesterol problems, changing their lifestyle, managing them with dietary and lifestyle changes along with the medications, to the point where they eventually need some type of procedure or workup for that, like a stress test, echocardiography, or a heart cath. This is one spectrum of that. And also this is one of the specialty which is very intellectual. You have to build a relationship with the patient. You have to be very thorough whenever you are seeing a patient. They used to say that older people, and there is an age like above 50 or 60, you're going to have a heart disease. But now, because of our diet changes and a lot of risk factors, age is just a number. So we are taking care of the patient starting from any age, from 20 all the way to 90 or 100. So wide spectrum, taking care of either acute patients like someone is having a heart attack and you're doing a procedure and you save someone's life. And by the time you come back and after you're done, you tell the news to the patient or their family, and the smile and the reward you get, that's worth it, you know. So I like the passion and being enthusiastic, working in the lab or either working in the office, managing multiple risk factors and the preventive aspect of this specialty. So two different spectrum or extremes which I like about this specialty. I'm originally from Pakistan. I grew up and in a small town is called Kasur. It's one of the small city in one of the major province in Pakistan. I have one brother and three sisters in my family. I am the only one who is a doctor in my family, and in fact in my whole immediate family relatives, because we do have our own family business, and I'm the only one who wasn't interested in the business. So I would pursue my career in the medicine, and my parents, they support me. They sent me for higher education in a bigger city, and eventually I took exams. I came to US. When I came here the first time, it was a little bit challenging for me because of various reasons, like culture difference, and also the healthcare aspect was a little bit different here compared to what I saw, because we don't have too many facilities back home. We rely mostly on bedside manners, but here when you come, you do have bedside manners and also the imaging facility, and you get your results very soon compared to back home because of the lack of the facilities. So I complement my bedside skills and clinical skills along with the diagnostic imaging and provide the best care as well. And beside, I like hiking. I love to cook as well. I like a lot of Pakistanis and Asian dishes as well. And also like to spend time with my family and friends as well. If we compare the healthcare aspect between Pakistan and US, it's a little bit different in terms of either at bedside manners and the imaging facilities. Like because of the lack of the facilities which we have here, unfortunately we don't have in Pakistan. So for example, if you're having a patient who is having an heart problem, like any type of heart failure, and you did an echocardiogram, if you order that echocardiogram here, you will get the results relatively sooner compared to back home, you know. First of all, we do have limited facilities and the patient load is very high. So they're gonna be in that queue to wait for that echo to be done, you know, and to be read by a physician. And it's gonna take at least months to get it done, you know. But here, if I think a patient needs some type of any imaging like a stress test, heart monitor, or echocardiogram, and I usually get it pretty sooner, you know. So at least I can correlate my clinical findings with the imaging finding, which will obviously supplement, and I can treat that patient accordingly. And also here the patients are more educated, and it's much more easier for us being as a physician to tell them about their risk factors and to educate them. But because of that barrier back home, is sometimes it could be more challenging and stressful to talk about the patient about the risk factors because of unhealthy lifestyle. We do have a lot of genetic factors in the heart disease, and sometimes it's really hard to convince a young member in a family who does have heart disease to eat healthy and to be more proactive in terms of more diagnostic and laboratory tests because of the lack of the education. But here when you come, it's going to be much more easy because people do understand they have to be more proactive and have to be very careful and cautious about their diet and the smoking and the other risk factors. So I think that's one aspect. And second, about the research opportunities. I also like cardiology because there are a lot of research opportunities. Every day we find some new results, new guidelines, and that really helps us to manage patients in a timely manner. So there are a lot of research opportunities here, and that helps us to manage patients according to the current guidelines. But we don't have that many research opportunities back home. And also, there's also one thing which is very important. Here we do have different subspecialty physicians like electrophysiologists, heart failure specialists, general cardiologists, interventional cardiologists, structural cardiologists. So everybody is specialized to do a part of the cardiology field workup. But back home, maybe there will be only one cardiologist who is doing everything, and there is a lot on his plate, to manage everything starting from general cardiology to intervention to electrophysiology to heart failure. So that is what we call that multidisciplinary approach, which I think really helpful. So you can put more attention and give more time to the patients relative to your specialty, because I'm an interventional cardiologist, so I know how to treat the heart attack, the blockages, but I'm not good at pacemakers because that is a part of electrophysiologists, and there are other doctors for that as well. So I think that's a good aspect as well. Yes, I recently had a patient. She was 84-year-old female, came with a heart attack, and which we confirmed by doing an EKG because she had chest pain, which was going on for a couple of hours. So I took that patient to the lab because in interventional cardiology, if someone is having a heart attack, they say time is muscle. Because the earlier you do that procedure to open up the block artery, the better there is a chance that they will have a good heart function and normal recovery time, So we took her to the lab, we did a procedure, we find a blockage, and we fixed that. And the patient, when I was done, I came back and talked to the patient family. They were really happy because the way they saw their relative before I did the procedure, and by the time I was done, it was a completely different picture, because she was crying because of the pain. She wasn't feeling good for a couple of hours, but now she is completely comfortable. She doesn't have any more chest pain and she is doing fine, She could have died at home if they wouldn't have brought her to the ER, because as I say, time is muscle. The longer you stay at home, the higher the chances that your heart function is gonna get affected and you're gonna have more problems. So when I told them, they were really happy and they thanked me a lot. So that satisfaction which I got by telling them about their relative, that she's doing fine and she's out of that danger, that is one of the best example, I would say, that keeps me motivated to do more in my field, to provide more care at every effort. So I think that is which we always do, to provide good care to the community, but in cardiology at a timely manner as well, because I said time is matter, because time is really important. So we have to do best in that time frame as well. Heart disease in women is as common as in men as well, especially after 50 or after menopause. Before menopause, they do have a protective effect from estrogen, but after they pass that stage and comes into their menopause, they have the same risk factor, same probability of heart disease compared to men as well. And sometimes they probably even have a slightly higher chance of heart disease compared to men as well. Studies have shown that most of the time we underdiagnose or we misdiagnose females with heart disease compared to men because we underestimate the probability or severity of heart disease. So I usually take more time and effort every time if I see a female patient, especially after menopause age, So I want to make sure that I don't miss anything, which is very important for me to know. And also, women, especially if they do have multiple risk factors for heart disease, they can have more complications. So they should be more worried about that. And also they can have some atypical presentation for heart disease. If someone is having a chest pressure, which goes to your neck or jaw, and especially to the left arm, and that's mean you have a chest pain most likely coming because of the heart disease. But that is not the case every time in the female patient, because they can have some atypical symptoms like indigestion, some nausea, vomiting, difficulty breathing, which could be a sign or symptom of heart disease or heart attack as well. So if a female patient is not having a chest pain but having those symptoms, so that doesn't mean they are not having a heart attack. There could be a very high likelihood or possibility that they are having a heart attack, and we should be more careful and bring them to the doctor or to the ER to have it checked out. So I think it's very important to provide education to female patients specifically about the other symptoms which can mimic or which can be indicative of heart disease, so we can provide them care appropriately in our emergency room or in the outpatient setting as well. The favorite part of being a cardiologist is reflect on what I have mentioned so far, like to interact with patients in both settings, outpatient settings, managing their chronic problems, and then talking about the education and awareness regarding the risk factors for the heart disease, and working in the cath lab, which can be stressful, but I like that because there you can manage patients and save lives, So my father died of a heart attack, and I couldn't save him because I was a medical student at that time. But at least whenever I have a patient who is having a heart attack and I do a procedure and open up the blocked artery, and I tell myself that I saved someone else's life, which I couldn't do that for my father. So it gives me a lot of relief and motivation to continue to do more. So I think this is the best part about being a cardiologist, and that's what I would like to do and continue to do and continue to thrive in my specialty, and will try to do better every day.